But I'm going to go ahead and start the case study. These are my disclosures. This is a 71-year-old African-American male. He has a history of a non-STEMI stent to the ramus. At 53 in 2006, he had a previous angioplasty in 1987. He has HeFH, his Dutch lipid score is 9, statin-naive LDL is greater than 190. He came to my clinic in 2021 due to his hyperlipidemia not obtaining target LDL. He's intolerant to rosuvastatin, atorvastatin, lovastatin, and simvastatin, secondary to myalgias. Currently, he's on his amlodipine 5, aspirin, ezetimibe 10, finasteride, metoprolol 25, and his synthroid. These are his vital signs, which are normal on his amlodipine. So at his consultation, these were his lab values, total 256 and an LDL of 183 on his ezetimibe. So what are the next steps? We certainly know that this young gentleman is at residual risk. What would we do next? The great thing is we have multiple things in our arsenal now that we can try on this young gentleman. And just for time's sake, I'm going to continue going through the case study and talk about what I did. So this is his family history, which is quite significant, with a mother with an MI who also had HeFH, father had heart disease and high cholesterol, grandparents with heart disease. He is very active. He walks 3 days a week, about 3 miles per day at a 20-minute per mile pace, tries to follow a healthy diet by watching his red meat, eating tons of vegetables. Past medical history, hypothyroid, as you saw, he did have non-sustained VT at the time of his MI. His MPI in 2021, you saw a small amount of infarct to the RCA with minimal peri-infarct ischemia. Everything was essentially normal. Carotid, no evidence of stenosis, but he did have plaque in his carotids. So when he came to see me, based on his FH and his family history of premature ASCVT, I wanted to obtain an Lp(a) because no one had drawn an Lp(a) on him in the past. And we know 30 to 50% of patients that have FH will also have elevated Lp(a). And the NLA statement guidelines state that all individuals should have an Lp(a) checked at least once in their lifetime. So his Lp(a) was 264 nanomoles per liter. High risk is greater than 125 nanomoles per liter. Not that this information surprised us any based on his family history, but it does kind of help us determine how much more aggressively we want to continue treating him. I also obtained an echo due to the prevalence of aortic valve stenosis, 31 to 39% higher in the FH population than in the general population, which did show mild aortic valve sclerosis without stenosis. So what were the next steps after this? So obviously, the next thing we do is decide where do we want to obtain his LDL, his target. And this is a conversation I often have with patients because in my lipid clinic, almost 1 out of 3 patients come in and they all want to treat their cholesterol with diet and exercise. No one wants to be on medicine anymore. And so they're really resistant. You have to educate them and teach them where we want them to be, and then how is it that we're going to get them there. So we have the AHA guidelines, the ESC guidelines, the 2022 consensus statement, and the ACE guidelines for your diabetics. But what we now know, certainly through the consensus pathway in 2022, For these residual risk secondary prevention patients, targeting LDL to less than 55 really seems to be where we want to be. So for this young gentleman, I told him we wanted to treat his LDL less than 55. So the next question is, how do we get him there? So in 2021, after all of this, I started him on evolocumab, 140 milligrams self-injection, every 2 weeks in order to obtain 50 to 70% reduction in his LDL. So you can see 3-month follow-up afterwards, total went down to 184, LDL went down to 118. So this was great. We had a wonderful reduction, but still not at our target LDL of less than 55. So we discussed, do we want to maybe add a statin, low dose, twice a week or every other day to the evolocumab? He was absolutely resistant. I'm not going to take a statin. It put me in a wheelchair. I'm not doing it again. So he's already on ezetimibe, so the question is, what is it that we do next? So we wanted to give Rapath a little longer and work on his diet diligently. In the meantime, he complained of chest pain and ended up going to the cath lab. And you can see here that he had non-obstructive disease on his cath and did a FFR. Everything had plenty of blood flow, but certainly this man is at residual risk, and we need to diligently get his LDL down. Follow-up lipids in 2022, LDL was down to 72. We had not changed anything previous to that other than his diet, his ezetimibe, and his evolocumab. So we had multiple discussions regarding adding bempedoic acid, 180 milligrams every day. This, we've already talked about the bempedoic acid, the side effects. This does require prior authorizations through many of your payers. I do educate my patients that if you've had gout before, the likelihood you would have a recurrence of gout is high when you do add the bempedoic acid. But finally, he was in agreement, seeing that his LDL was not getting where it needed to be. So in January of this year, after putting him on the bempedoic acid with the evolocumab and the ezetimibe, total cholesterol is now down to 108 and the LDL is at 46. And he is now at his goal. We changed him over to Nexlizet, which combined the Zetia and the bempedoic acid in one pill to decrease pill burden. And he is now at goal.